us. Nadine, you can start.
Yes. Good everyone. Can you hear me?
Yes, we can.
Okay. Good evening, everyone, and thank you for joining AMFNet's webinar. I'm Nadine Haddad, a Senior Technical Officer at AMFNet, and I'm pleased to be introducing today's topic. Today, we are talking about advancing hepatitis elimination in the Eastern Mediterranean region, specifically tackling strategies, challenges, and collaborations. The Eastern Mediterranean region deals with a substantial burden of viral hepatitis, predominantly viral hepatitis B and hepatitis C, posing remarkable challenges to public health systems and socio-economic development. Across the region, there are varying prevalence rates of chronic hepatitis C and B infections that are influenced by diverse transmission dynamics, including unsafe medical practices and vertical transmission from mother to child. While Egypt received in 2023 the official certification for becoming the first country to achieve the path towards elimination for hepatitis C, Pakistan still bears the greatest burden of viral hepatitis B among the Eastern Mediterranean countries, with more than 3 million cases corresponding to a prevalence of 1.6%. Addressing the burden of hepatitis demands a comprehensive and a multi-sectoral approach, emphasizing on prevention, screening, treatment, and health system strengthening, alongside efforts to mitigate social determinants of health and promote regional collaboration towards achieving hepatitis elimination goals as outlined by the World Health Organization. In today's webinar, the Eastern Mediterranean Public Health Network and the Coalition for Global Hepatitis Elimination aim to raise awareness and mobilize collective action towards eliminating hepatitis as a public health threat in the Eastern Mediterranean region. I'm pleased to introduce first Dr. John Ward, creator and director of the Coalition for Global Hepatitis Elimination of the Task Force for Global Health. Globally, Dr. Ward is an advisor to African Union Hepatitis Technical Working Group and WHO, including the PAHO Technical Advisory Committee on Disease Elimination and the WPRO Hepatitis B Expert Resource Panel. Over a 13-year tenure, Dr. Ward directed the US CDC Division for Viral Hepatitis with responsibilities for viral hepatitis surveillance, prevention, and research. At the national level, Dr. Ward developed recommendations for vaccination and screening, authored the first action plan for viral hepatitis prevention. He initiated the US Academies of Science recommendations for viral hepatitis elimination and guided the launch of pioneer HCV elimination programs. Dr. Ward is a professor in the Huber Department of Global Health at Emory University, Atlanta. Welcome, Dr. John, and thank you for joining, and over to you.
Thank you very much for that kind introduction. It's my pleasure and honor to be opening this webinar where we can focus on hepatitis elimination in the Eastern Mediterranean region. After several decades of public health experience at the U.S. Centers for Disease Control and Prevention, I had the privilege there to direct the Division of Viral Hepatitis, where I became very focused and committed to bringing together the prevention, the testing, care, and now the curative treatments we have that make the elimination of hepatitis B and hepatitis C possible. If we are successful globally, we can avert 7 million deaths from liver disease and liver cancer by the end of this decade if we can bring together the effective vaccinations, reliable tests, and curative treatments to the people that need them so that we can avert new infections and premature mortality. What you'll hear today on the webinar, within this region, we have the world-leading example of how a country can work together with all partners to bring together the essential components to put together a highly effective hepatitis elimination program that's achieved remarkable success, as you mentioned earlier. At the same time, you'll be hearing from a country that faces the greatest challenge in the world in overcoming a large burden of disease, particularly for hepatitis C. And as you'll be hearing from my colleague, Dr. Qureshi, in a moment, about 1 in every 5 people with hepatitis C globally are now in Pakistan. And our job as a coalition, in part, is to help bring all the partners together to share lessons learned so that we can benefit from countries in Egypt and apply those to countries like Pakistan. And so we look forward to the discussion today. Thank you.
Thank you, Dr. John. Thank you so much. We will start with the first presentation on the current epidemiological situation of hepatitis globally and within the Eastern Mediterranean region, with a focus on Egypt and Pakistan. The first presentation will be focusing on the Eastern Mediterranean region, and I'm pleased to introduce Dr. Ahmed Sabri, Technical Officer at WHO EMRO, Department of Communicable Disease. Dr. Ahmed's main areas of work include strategic information, advocacy, and strategic planning for HIV, hepatitis, and STI. Thank you for joining, Dr. Ahmed, and over to you.
Thank you very much, Nadine, and it's my pleasure to be with you today among this very amazing and intelligent panelists, and with all the audience to talk about viral hepatitis in the Eastern Mediterranean region. I have a presentation, so let me share my screen. I hope you can see. And now it's in the screen mode. Let me first start with what do we mean actually by hepatitis elimination, because that's a good start for all the audience to understand what do we mean by the elimination and what is WHO proposing to reach the elimination. So in 2015, it was the first global health sector strategy on viral hepatitis. And that was the first call globally to ask countries to eliminate viral hepatitis as a public health problem. And this meant is that we want by 2030 to achieve a 90% reduction in new infections and 65% reduction in mortality. But we had a challenge back then that many countries didn't have a baseline for 2015. So the 90% reduction in the new infections and the 65% reduction in mortality that we wanted to achieve by 2030 was compared to 2015 as a baseline. But most of the countries didn't have that baseline. So WHO actually converted that into absolute targets that's being asked or proposed to achieve, which very much translate that relative reduction. So the new figures or the new modified targets, as I'm presenting it here, so for mortality, we want to reach annual mortality for hepatitis B to less than 4 per 100,000 population, and for C to less than 2 per 100,000. And there is actually a new guidance that combined both B and C, so for countries to achieve less than 6 per 100,000 population. For the incidence, it's for hepatitis C to achieve less than 5 new hepatitis C cases per 100,000. And for B is which is actually the SDGs indicator to reach less than 0.1% prevalence in the population which is under 5 years old, which is the proxy for the incidence. Let me re-say those targets, because this is very important for countries and for our audience to understand that these targets are called impact targets. That we are supposed to reach by all the countries by 2030. And this is what we will define and call countries that they achieved elimination by reaching those targets. So for mortality, combined by both B and C, less than 6 per 100,000. For incidence, for C, less than 5 incident cases per 100,000. And for B to reach less than 0.1 and for the prevalence of in the population under 5 for B. How to achieve those targets? WHO also proposed 5 key interventions That's if we do this, we will be able to eliminate hepatitis by 2030. 4 of these are around the prevention, and 1 is about scaling testing and treatment. Let me take you to these 5 interventions. The first one is to achieve the 3 doses of hepatitis B vaccine to reach 90%. Prevention of mother to child, which is basically the birth dose vaccination to reach 90% coverage, to work on both blood safety and injection safety, and to achieve 100% safety in both the blood donations and also the injection safety. Harm reduction, this is very specific to the population who inject drugs. We want to reach those population and distribute safe syringes so they don't circulate the virus. And of course, testing and treatment to reach 90% of the population with viral hepatitis, and at least treat 80% of those who are eligible. So these are the 5 interventions that every country is being asked to strengthen and improve and to work on to be able to reach the elimination that's defined by WHO. How are we doing globally? There are like new data that came. For hepatitis B, we are almost reaching 300 million. For hepatitis C, we are around like 60 million. Like the mortality attributed to both B and C is actually on the rise, although we are noticing a bit of a decrease in the incidence. And I will take you more specific to the situation in the Eastern Mediterranean region, but just wanted to lay that global picture first to make sense of the regional picture as well. Globally also, we are not doing much for the testing and treatment for viral hepatitis. Almost 10% only of people with hepatitis B like know that they are that they have hepatitis B, and less than 2% are actually receiving the needed treatment. For hepatitis C, it's slightly better, but not much. Almost 21% of those with C are aware of their status or diagnosed, while less than 14 or 13% are accessing like the needed treatment. Now I want to take you to the situation in the Eastern Mediterranean region, and before that I just wanted to show this map because it's a bit confusing sometimes with the MENA region. And so the Eastern Mediterranean region, we are actually composed of 22 countries. It goes all the way from Morocco on the far left, all the way to Afghanistan, Pakistan, Iran, but we don't have Algeria, so that's part of another WHO region. So we have 22 countries, and the statistics I will present in the next slides is representing the 22 countries. So how is our situation with both B and C? So for hepatitis B, we are coming fourth after the African region, the Western Pacific, the Southeast Asia, in terms of the prevalence. We are almost 2.2% in the prevalence of hepatitis B. That's translated into 15 million people who have hepatitis B in the region. For hepatitis C, after all the achievements that we did, but we are still leading in the prevalence. That's the orange bars in the graph. We are at like 1.6, 1.8% prevalence. That's translated into 12 million people with hepatitis C in the region. Our incidence for hepatitis C is still the highest. In 2022, it was estimated around 183,000 new hepatitis C infections happened. Most of them actually happened in one country, that's Pakistan, and we will hear more about Pakistan in the coming presentations. For hepatitis B, we are around 86 incident like new cases for hepatitis B in 2022, which is also quite high number. In terms of mortality, hepatitis B was estimated to cause around 40,000 Hep B related death, while C is actually a bit more. It was estimated that it caused around like 56,000 deaths that were attributed to hepatitis C. To take you also a bit deeper into the country situations, where are those infections and which countries are affected the most? If you look at the graph on the right, that's the distribution of hepatitis C infections in the region. Basically, we are left out with Pakistan. Before, this graph had Pakistan and Egypt, but thanks to Egypt, they did the amazing job with hepatitis C. But now 80% of the infections in the region is located in Pakistan, while the rest of the countries combined make up to like 20%. For hepatitis B, we have like a bit of diversity. Pakistan is still contributing with a major proportion in the region, like 25% of Hep B infections in the region are coming from Pakistan. We have countries like Sudan, like Iran, Yemen, Egypt, Somalia contributing with like around 1 to 2%. Around like 5 to 6% each for the burden in the region. But we have a bit of a diversity for B, but for C, our problem mainly is in Pakistan. If you remember the second slide or the third slide I presented, I was referring to the key interventions that needed to eliminate hepatitis. And I wanted to show the progress of the region towards these 5 key interventions. So in terms of the vaccination for B, we are at 84% coverage, while the target is 90%. It's improving, but we still have a gap to fill. While for burst dose, which is actually one of the biggest challenges in the region, and it's not improving much, we are at 34%, and you can see we have a long way ahead to reach the 90%. Big countries with hepatitis B still didn't introduce the burst dose, or if it's introduced, it's very implemented at a very low scale. Blood and the injection safety. I think we are in the first region globally in terms of unsafe injections. The last modeling suggests that around 8% of all injections in the region are unsafe, which is actually mainly driven by unsafe injections in Pakistan. So Pakistan is very much influencing the regional picture here. On blood safety, we don't have the data to describe how are we doing, but again, countries still reporting some issues with blood safety, and we continue to see outbreaks for bloodborne diseases that's related to blood safety in some countries. So I'm sure we didn't reach 100% yet. Harm reduction, one of the weakest components in the region. We are at 27 syringes distributed per person per year, while the target is around 300. Testing and treatment, as I said, our situation improved much with what happened in Egypt. So now almost 35% of all the C cases in the region received the treatment. But our situation for B is the main challenge. Around 14% are diagnosed, and 2% are receiving the needed treatment. So I think we need a push in the region for hepatitis B. I just wanted to present some programmatic progress, just how our countries are setting up their programs to respond to viral hepatitis. I will just touch on some areas. So for governance, you can see that most of the countries already have like a team or a person or kind of a program within the Ministry of Health to take care of hepatitis. Not much of the countries, or almost half of the countries in the region, have valid national strategies. Also around like 9 countries have like technical advisory groups that's advising the Ministry of Health on what's needed to be done. But the involvement of civil society, which is a big component of the hepatitis response, is not very optimal. We only have 7 countries in the region involving the civil society and the advocacy, the service delivery, and the policy discussions, etc. And not much countries developed like advocacy strategy to put hepatitis high in the national agendas for health. Financing, which is very important, because if we need to do things, we need to find the money, we need to finance it. As you see, like only few countries in the region developed either operational plans and allocated money for it. And I think only 2 countries were able to mobilize some external donor funding for hepatitis. But the message here that the work that's being done to finance the response for viral hepatitis is still very, very limited, except for Egypt, and I think now coming Pakistan, you will hear about it. Other countries didn't mobilize a lot of resources for hepatitis. We will have few exceptions in the Gulf countries, like Saudi Arabia, they already did like some work, but most of the countries in the region is still lacking the needed domestic resources to respond to the burden that they have of viral hepatitis. Here you see that most of the countries have some policies in place, whether it's for the policies needed for blood safety, injection safety, the vaccinations. But if you see like the bottom of the graph, the vaccination for key populations is not most of the countries have this in place. While actually, if we need to work on hepatitis, we really need to address the key populations because they contribute to the magnitude of the problem, and I think they are a big or an important population that we need to reach out to be able to effectively work and respond to viral hepatitis, especially people who inject drugs. I just wanted to show a good example that happened. I know we have a panelist who will talk about Egypt experience in details. I will just touch on it from a regional perspective. Egypt once had the highest prevalence of hepatitis C in the world. I think in 2014, the demographic health survey showed that the prevalence is like 4.4% among the age group 1 to 59. It was a long-standing public health problem. It happened because of the schistosomiasis injections back 40, 50 years ago. And it actually led to many people suffering from like different types of liver cancers, which was putting a lot of financial burden in the health system. And it really needed a big public health approach to respond to the problem in Egypt. Egypt, many steps happened, and again, you will hear about it in details, but the key milestones that happened, the local production of the needed medication, that's around 2014, 2015. There was a large-scale testing and treatment campaign, the 100 million Sahha, that happened between 2018 and 2020. 60 million people were screened. More than 4 million people received the treatment. A lot of work happened in the blood safety to achieve 100%. A lot of work happened in the injection safety. And that opened also the door to expand the harm reduction program in the country, which is, I know the country is now effectively moving towards strengthening that program with a big vision. In summary, these are Egypt achievements in terms of the interventions and the impact that was created. I just pulled this slide from our validation process that looked into Egypt work, which ended up by granting Egypt the gold tier pass to elimination of hepatitis C. I will not go into it in details. I know it's coming in later presentations, but testing treatment happened at a very large scale. They reached everyone, and at the end it actually led to creating the impact on the incidence and mortality. They are a bit like they are very close to achieve the targets for the elimination, but that's also I think will come by 2030 or even before. And this is from October last year, when Egypt was awarded the gold tier pass to elimination of hepatitis C, the biggest achievements in the region and globally, #1 country globally that implemented such a program. And I think we have a lot to learn from Egypt experience. And I think now Pakistan also is looking to Egypt as a reference and as example, and they want to follow that path as well. Just to summarize, we have some opportunities and we still have challenges in the region. Our opportunities, like we have a good country example from Egypt that's implementing the biggest public health initiative globally to respond to hepatitis C. So there are like many lessons for other countries. COVID-19 introduced a very good diagnostic capacities that could be leveraged also for viral hepatitis. There was like a historic agreement reached by CHAI and NDHIP that can help low middle income countries like secure hepatitis medications in a very low cost. In 2022, WHO developed the Global Health Sector Strategy and the Regional Action Plan. It's actually built around the integration of services and health system strengthening. So we don't want to countries to push for hepatitis as a vertical program, but we want to build a health system that can respond to viral hepatitis. So we have key interventions and key actions that's developed, and I think now we are working with many countries to take that regional action plan and the global health sector strategy recommended intervention and actions into their national strategies. But still, we have many countries with weak hepatitis programs. They don't have the needed resources to be able to implement services. The cost of the medications and diagnostics is still high in some countries, and the secured price deal might not serve all the countries, but this is something also to explore. Involvement of civil society is limited compared to the HIV one, and the data, which is very important. I think most of the countries lack key essential data that can guide the hepatitis response. So this is something also that we are trying to work with the countries on to strengthen, because if you need to design targeted and effective interventions, you need data to work with. In conclusion, our region made some progress in some interventions like the vaccination for hepatitis, like testing and treatment for C, but we still have a long way ahead for other interventions like the burst dose, like injection safety, like harm reduction, and testing and treatment for B. We have policies, we have guidelines, but these are not fully translated into services on the ground because of lack of financial resources for this. We have good success stories in the region, that's Egypt, that can enlighten other countries such as Pakistan to move towards elimination as well. There are some opportunities for countries like the price reduction agreements, like the diagnostic capacities that were introduced through COVID-19. And I think countries should leverage these opportunities towards viral hepatitis. And we really need countries to secure domestic resources so we can implement services up to scale. With that, I conclude my presentation, and I'm happy to take any questions. Over to you.
Thank you. Thank you so much, Dr. Ahmad, for this interesting talk. We will have the session for the question and answer at the end of the webinar, but I would like to remind everyone to leave their questions in the Q&A tab. Next, we will be learning more about Egypt's successful experience in our next presentation with Dr. Mohammed Abdel Fattah Abdelaziz. Dr. Mohammed is a medical epidemiologist with more than 20 years of experience in various posts at national and international levels. He is currently the Undersecretary for Preventive Affairs at the Ministry of Health and Population in Egypt, supervising the National IPC Program, the National Surveillance and Epidemiology Program, Quarantine Authority, the National Extended Program for Immunization, Communicable Disease and Control Administration, and One Health Unit. Dr. Mohammed is a member of the Scientific Council for the IPC Fellowship, the Egyptian Board, and he's the team lead for IHR, the National Focal Point for Egypt, and a member of the Global IHR Review since 2022. We are pleased to have you, Dr. Mohammed, and over to you. Thank you.
Thank you very much for you all. It's an absolute pleasure being here to be part of this webinar hosted by Infinite. This is good for the region, and I'd like to share some experience from Egypt. Might be helpful for other member states, and I know very well we are all learning all the time. Indeed, I'm finding some problem in sharing my screen. Do you hear me, Diana?
Yes, we hear you, Doctor.
Okay.
And we can see your screen.
Okay.
Yes.
This is the story. This is a long journey by Egypt, not only related to the Ministry of Health and Population. It was whole country approach, and we couldn't achieve this gold tier from WHO without the support of the government, the Egyptian government. So it was a whole country approach to achieve this. Are you sharing my screen or I'm sharing it? Yeah. Anna, are you sharing my screen or my presentation, or I'm sharing it? Because I cannot. Let's start first with the hepatitis C virus prevalence in Egypt. Since 2001, we called it the silent epidemic because some studies suggested that the prevalence of Egypt more than 20 or even 30%. So the first intervention implemented, it was the introduction of the first dose, the third dose of hepatitis B. After that, we started our national program for infection prevention and control in 2003 because we found that the prevalence of, this is the DHS implemented in 2008. It was by PCR, it was 10% approximately. And the hepatitis C virus antibodies, it was about 15%. This is according to the national DHS in 2008. Some efforts implemented in Egypt to 2015 until we reached the prevalence of hepatitis C up to 7%. Next slide, please, if you can. The hepatitis B program, as I said, it started in 1992 by introduction of the third dose of hepatitis B vaccine. After that, the decision of blood products screening for hepatitis B, hepatitis C, HIV, AIDS, and syphilis. In 2003, we started our national program for infection prevention and control, and the establishment of the National Committee for Viral Hepatitis, it was in 2006. After that, in 2014, introduction of the brands of direct-acting antivirus, and the National Technical Group. In 2016, the introduction of generic DDAs and hepatitis B vaccines, the birth dose. In 2017, the drop of the patient visits and the first targeted screening we implemented in 2017. In 2018, it was the crucial intervention from the Egyptian government by the we conducted the 100 million healthy lives presidential initiatives under the direct supervision from His Excellency, our President, Abdel Fattah al-Sisi. Next slide, please. This is the phases of the campaign. We started in October 2018 and we ended in April 2019. By 6 or 7 months, we covered these 27 governorates we have in Egypt. Next slide. This is the types of screening sites. As I said, it was whole country approach. So we didn't depend only on the healthcare facilities related to the Ministry of Health and the Population. We included every and each available site for the screening, especially the public places. We included more than 4,000 primary healthcare units. We included 382 general, central, and even university hospital, and we included 135 mobile clinics, and we used also 215 youth centers, and we used mobile teams located in big squares, governmental buildings, any place we can find people, we reached it and we implemented the screening. Next, please. This is the inputs of 100 million health life presidential initiatives. We recruited more than 58,000 frontline healthcare workers. We conducted more than 5,000 central TOT training, and we implemented more than 53,000 peripheral training. The average screening per day in 2018, it was 240,000 persons per day. The time of the screening took average 20 minutes per person. We achieved the testing sites for PCR testing. We already established 77 testing sites for PCR. Next, please. This is a summary of 100 million healthy life presidential initiatives. We used everything. The mass media campaign, we recruited 100 call center agents working to 24/7, average 240,000 screening per day. We used more than 7,000 healthcare facilities. We used only the document needed for the process. It was the national ID required, and everything was, and until now, is free of charge. The we implemented online registration system for the database. We performed, as I said, the rapid testing, and after that, the electronic dashboard and the referral to the viral hepatitis treatment centers, sample handling for PCR centers for testing, treatment for eligible positive cases, and even follow-up for the missed cases. And after finishing this process, the certificate of virus-free for the person. Next, please. The campaign achievement, it was clear for us after the mass screening we implemented for more than 63 million population. We found that at age group 18 years and more, the prevalence of hepatitis C was 4.5%. And for the age group from 15 to 17 years old, it was 0.4. And for the age group from 12 to 14 years, it was 0.2%. And among our guests or refugees, it was 0.7%. And for special groups, including immunocompromised and immunosuppressed, it was 14%. Next, please. This is the distribution of the hepatitis B, the prevalence of hepatitis C, not only limited to our governorates, but up to the districts and the catchment of primary health care units covering all Egypt. And you can see it was somehow concentrated in the Delta region or Delta governorates. Next, please. This is the process WHO report to verify our screening campaign in 2018-2019 between the President Abdel Fattah al-Sisi and the Director General of WHO, Dr. Tedros Adhanom. Next, please. Elimination best practice from our experience, it was the integration. We implemented a strategy, patient-centered programs, and we implemented HIV elimination, mother-to-child transmission, and even the mental health. And we implemented digitalization for everything, interfacing platforms between primary healthcare facilities, secondary and tertiary healthcare facilities, for the referral mechanism and the capacitation for the healthcare worker, for the laboratory, for the IT surveillance system, and even with the non-governmental organizations. The most important issue, I think it was crucial in our experience, it was the localization or tech transfer for some important testing mechanism and medication. Next, please. This is the most important issue from our side. This is the cost of fragmented purchasing of the medication for the treatment, for the diagnostic, and the mass purchasing. You can see the drop in costing between the fragmented purchasing from 21 USD, and we reached in 100 million healthy initiative, it was 5 USD only. Next, please.
Dr. Muhammad, may I just interrupt to remind you that you have 3 minutes.
Okay. This is the direct acting antiviral prices for 12 weeks treatment in USD brand versus generic. It was more than 10 times drop in the price, because all the time the mass implementation of or intervention, the cost is less than the fragmented or individual treatment. Next, please. Now, what we achieved, this is the prevalence of hepatitis C till 2022. It's by RNA, it's less than 0.4%. It's exactly 0.38% in a survey we conducted in 2022 in the age group from 15 to 59 years old. Next, please. This is the steps or the journey for the submission of to achieve the gold tier from the first version of the dossier for national elimination dossier. Next, please. This is the indicators for the gold tier target, hepatitis C diagnosis proportion. The gold tier target is 80% of people living with chronic hepatitis C are diagnosed. We achieved 86.7%. The treatment proportion, 70% of people diagnosed with hepatitis C are treated. We achieved 93.7%. For blood safety indicator, The screening is 100%, injection safety is 100%, even harm reduction, it was 100% coverage increase. Next, please. Egypt validation toward the elimination. This is the steps of validation until we the recognition of the gold tier in 9th October 2023. Next, please. This is the achievement of the gold tier. Next, please. Next, please. This is from, as my colleague shared, the next step. What about the elimination sustainability plan? Blood injection and blood and the injection safety, improve governance in blood donation, increasing capacity for safety syringe, and all the time we are promoting the National Infection Prevention and Control Program, and also we are working in harm reduction services, in the diagnosis and the treatment, continuation of diagnosis and treatment efforts, and enhancing the active surveillance and the routine surveillance at all our surveillance sites, safely and monitoring, strengthening the surveillance, the best management. But what is the most important here? It is, as we all agreed, it should be a whole country approach. Each country should use each and every available resources for the elimination efforts. Next, please. This is a special acknowledgement for for the National Committee headed by Dr. Wahid Dos, our hero, Dr. Muhammad Hassani, the Minister's Assistant for Public Health Initiative, and the WHO partner and all organizations. Allow me to say that no country cannot achieve that alone. This is about health diplomacy with the support of the medical, the multinational companies and the local companies, the national companies we have, even our partners, the World Bank, WHO, all UN organizations, and even we cannot neglect the role of Infinite in support Egypt in several areas. Thank you very much for allowing me to be here with you. Thank you.
Thank you so much, Dr. Muhammad, for this insightful presentation. From Egypt, we will move to Pakistan for our next presentation with Dr. Huma Qureshi. Dr. Huma is a consultant gastroenterologist in the private sector. She was the executive director of Pakistan Medical Research Council till 2017. In 2007, she conducted the landmark survey of the prevalence of hepatitis B and C in general population of Pakistan. Currently, she's the focal point for viral hepatitis for the government of Pakistan and has developed a national hepatitis C elimination project for the country. In recognition of her outstanding services in the medical research, Dr. Huma was decorated by the government of Pakistan with a civil award, Tamghal Imtiyaz. May I please remind the speakers to stick to the allocated 15 minutes so we can have enough time for discussion, and please, whenever you have any error or issue in sharing the screen, we can do it for you. Thank you so much. Over to you, Dr. Huma.
Thank you. Thank you very much. And hello, everybody. So following Egypt, I'll be presenting to you the prevalence of hepatitis C in Pakistan, what issues and challenges we have and how we are meeting them. And following the announcement of the Prime Minister's program for the hepatitis C elimination, how are we going to move forward? So this is all I'm going to share with you. I have no conflict of interest. So first, I'll take you through the epidemiology of hepatitis C in Pakistan. As you all just heard that we have the highest hepatitis C infected population in the world. Our prevalence is 7.5%, which translates into about 9.8 million viremic or infected cases. To find one positive case, we need to screen about 12 people. And we have a population of 253 million. So to find these 9 million infected cases, we need to screen 164 million population. So you can imagine it's a huge task as compared to Egypt. Our incidence of HCV new infections is 0.1% or 110,000 cases per year. For the risk factors, as you all know, that we still are facing with the issues of improper screening of blood donations. We have unsafe therapeutic injections, which are used for common ailments, and we have improper sterilization of invasive medical devices, leading to poor infection control, leading to all these issues. So for the improper screening of blood donations, the provincial blood banks are being strengthened and the private blood banks are being deregulated. For unsafe injections, the government is trying to introduce the auto-disable syringes. They have passed the bill already, and they're kind of going in transition from the multi-use syringe to auto-disable syringe. And for the poor infection control in the hospital settings, we are taking the support from the Healthcare Commission to look into these issues at the hospital sites and put the sterilization and disinfection at the right corner. For the cascade of care of hepatitis C, we have got 10 million people, as I told you earlier, who have the virus or are viremic. And till 2022, almost about 30% of this population, 10 million, which is about 2.7 million people, have received the DAAs. With a 97% cure rate, we think that almost about 2.6 million people have been treated. And Pakistan is the largest user of DAs in the world for the past 10 years. And this is the data from the Center for Disease Analysis, USA. So as you all know that we have a devolved healthcare system. So following the devolution, the provinces address all their health issues with their own budgets. So there's a large hepatitis C infected population, which is mostly residing in two large provinces of Pakistan. There are 4 provinces, but 2 have the largest burden. And it is almost becoming impossible for the provincial governments to cater for their needs. So the federal government was therefore asked to rescue and support hepatitis C elimination from Pakistan. From the federal, support should come to the provinces. So this is the Prime Minister's Hepatitis C elimination program that is being launched on the Hepatitis Day in Pakistan. The total cost of this project is around 35.81 billion, which would be supported by the federal government. This is all domestic funding, while another 35.5 billion would be raised by the provinces themselves. So total cost is about 70 billion, and it's all local funding. Currently there's no funding from outside. So as I told you earlier, we have got a total population of 253 million. We shall screen more than 12 years persons more than 12 years of age, which constitutes about 164 million people. In the first phase of the study, lasting for 3 years from 2024 to 2027, about 50% of this infected population would be addressed, which is about 82 million. So the federal will support all the screening for all these 82 million people. It will support the PCR testing for 30% of the population and will support treatment for 50% of the population. So by and large, out of the 82 million, about 6.7 million will be found HCV positive. They will undergo the PCR testing, and 6.4 million will be PCR positive, and about 5.6 million will then go to treatment. So it's a huge task that we are taking, but hopefully without this, I don't think we can eliminate the disease. So how this program will be implemented, as I told you earlier, that it's a federal program, plus the 4 provinces will also contribute from their own funding. So we have developed a project or a PC1. The PC1 has the number of infected cases which are present in each province. So depending upon the number of infected population in each province will select few of its high HCV infected districts, and it will screen all people who are more than 12 years of age in those districts, and then undertake the reflex testing as soon as somebody is found a rapid test positive. and then the blood would be sent to the lab for testing, and then those who are found positive, they would be provided treatment. So that's how it will work. So 50% would be selected through the infected high-risk districts. When we talk about access to care, I'll be talking to you about the use of the rapid tests, the PCRs, and the DAAs. And as you all know that in Pakistan, almost about 60% to 70% of the healthcare is provided by the private sector. So that's the major contributor to health. Followed by the civil society organizations and the NGOs who are also supporting the hepatitis testing and treatment. So it's a public-private partnership. We have a decentralized program and we undertake screening at the grassroots level, and we undertake PCR at a district level. We have got 4 provincial programs, and these programs have adequate number of PCR machines which have been present in the program and also received through the COVID pandemic. Then on top of it, we have got gene expert machines which are present in all the districts. So there's a good testing algorithm available at the district and the tertiary care hospitals. We undertake free screening for B and C and testing and treatment, but still we have got shortfalls, and these shortfalls may mostly occur because of the supply and the demand issues, because often the medicines and the supplies do not match. Sorry, can you see my screen? Oh, okay. I don't know. I lost my screen.
Yes, we can.
I don't know. I lost my screen. Anyway, I'm trying to go back.
Would you like us to share it, Dr. Huma?
Just a second. Just a second. I think I'm getting, yeah. So the next challenges, the next step are the challenges and the lesson learned. And the challenges are that we have seen that by and large, the community is very reluctant to come out for screening and testing. And then we have a paper-based data. It's not an electronic record. And then the supply and demand issues. So for this, the lessons learned and the way forward is that we have found out that we can access 75% of the population at home through the lady health workers and the vaccinators who have their designated homes and the areas where they can access the population. So we can very easily access 75% of the population, while the rest of the 25 don't mind coming to the hospitals or the healthcare facilities. Then once those who are found positive, one of the phlebotomists goes around the positive, in the area, and goes to the positive houses and collects the blood from these individuals and then brings it to the main lab. We have recently developed a hepatitis software, which is a national software, and it is being deployed in all the provinces, and all the people are using it. So we are getting away with the paper-based data. And then the supply and demand issues will be sorted out through the Prime Minister's program, which has a very strong supply chain software also. For the challenges and lessons learned for C, we still have populations which are not very well addressed. These are the key populations: prison inmates and children less than 12 years. So these will be addressed in the next phase of the Prime Minister's program, which would be from 2027 to 2030. While for the key populations, the Global Fund has agreed, and you all know, will test and treat HIV positive population who are B or C positive. So these would be tackled through the Global Fund. We have some achievements also, like we have a technical advisory group. Then we have developed, we got the Gilead sofosbuvir from in Pakistan through the access program of Gilead, and through this we were able to treat a lot of people. And following this generic branded sofosbuvir, we developed our own generic medicines in Pakistan in 2016, and this local production brought the price to really reasonably very low prices. And we know that Pakistan is producing the world's most cost-effective DAs, so there's no reason that we can eliminate the disease. Plus, we have also developed different treatment guidelines and the MTCT guidelines. So we are moving forward. So in conclusions, ladies and gentlemen, Pakistan has the highest hepatitis C infected population, with about 10 million people who are awaiting diagnosis and treatment. Domestic funding by the Prime Minister program will address the gaps in testing and treatment. Incorporating the birth dose in the extended program for immunization, I think that we have done a study and we found out that this is the most cost-effective way of preventing the mother-to-child transmission of B. There are many challenges in the screening, testing, and treatment of this large population, but I'm sure these can be addressed with the collaboration of all stakeholders. And like we heard from Egypt, if they can do it, we can do it, so we can eliminate hepatitis from Pakistan. Thank you very much.
Thank you so much, Dr. Huma, for the interesting talk about Pakistan, a challenging situation, but also about the countrywide efforts. Our next presentation will tackle the diagnostic and treatment innovations in the Eastern Mediterranean region with Dr. Amir Fahmy. Dr. Amir is a pharmaceutical and healthcare executive with more than 30 years of experience within the Middle East and Africa. Dr. Amir is currently supporting to extend the Egyptian hepatitis C elimination experience to Africa as part of FARCO's ambitious mission to eliminate hepatitis from Africa and the world by 2030. Over to you, Dr. Amr.
Thank you very much, Dr. Nadine, and thank you for having me. In fact, it's great always to think together of how could we save lives. And as a person whose father passed away because of hepatitis C, and it means a lot to me to see less families being affected by this disease. And as you know, there is one person in the world that dies every 80 seconds from hepatitis C. I share with Dr. Shireen Helmi, the chairman of FARCO Pharmaceuticals, the same purpose, who's my boss, and he is a global ambassador against hepatitis and with hepatitis elimination. As you know, and as mentioned in the presentation of Dr. Sabri, around 70 million people now, 54 million people with hepatitis C. Almost 400,000 people die each year from hepatitis C. 80% of them in the middle to low income countries. And Egypt, as one of those countries, was one of the significant, heavyweight countries in ammunition, in the fight against hepatitis. As we succeeded to bring Egypt to where we are now, we are happy to share the experience across the globe, and this is how we came to the Coalition for Global Hepatitis Elimination, and we are coming now to the meeting today, and we have been to almost every global event that is associated with this purpose of hepatitis elimination. To us, there are three main dimensions that we need to look at: the awareness about the disease and its management or prevention, the affordability either by the individual or by the healthcare provider or the sponsor, and as well as the accessibility of patients and population to the medicine itself. By the way, I have been through the Q&A questions, so I will try to address some of the questions while going through the presentation.
Thank you, Dr. Amr. We have a comment that the slides are not moving. If you can put the slides in a presenter mode.
Do you see? Okay, so I will stop
We
sharing.
still see the first.
All right.
Thank you. We were seeing the first.
Do you see now the slide changed?
Yes, we can see.
Yes, thank you.
Right. Thank you very much. So I was just addressing the awareness, affordability, accessibility part. As far as what we have done is that we had a major contribution to the disease elimination in Egypt. as we are the biggest Egyptian pharmaceutical manufacturer, but we have a commitment towards the population. And fighting the epidemic in Egypt was one of our major objectives. Most importantly, we were determined to make the treatment affordable and accessible. This has, do you see the slide changing now?
Yes, doctor. Thank you.
All right, thank you. In order to make this possible, we needed to implement the plan of developing effective, safe, and affordable cure. And for this, we looked into three main dimensions. The 12 Ds, I will try to be brief as much as I could because there are lots of learnings. But the treatment strategies, treatment reach, and treatment affordability are the three dimensions. In the strategy side, the direction of political will comes on the top. The presidential program, as Dr. Abdel Fattah presented, started from the beginning by saying, can we treat 1 million patients per year? The president of Egypt in 2015 said, can we treat 1 million patients per year of hepatitis C? And we wanted to have no one patient left who is diagnosed untreated by the end of 2016, which has actually happened. After that, we started, the president started to allocate budgetary support from the National Fund Tahya Masr. And in 2017, we started the screening in 7 months, as Dr. Muhammad mentioned, there are 63 million, 45 million people, adults, and then later on, the rest from the below 19 years of age, reaching a 63 million people screened. But it couldn't have started unless there was a political will at the national level that supported the transformation. From a pharmaceutical manufacturing side, where we worked not only on manufacturing the medicine, but also on having ambassadors for the awareness of the importance of hepatitis elimination. So we had global ambassadors and local ambassadors. We had Ahmed Hassan Mido, who's a football player in Egypt, Mido, and then we had Dani Alves, Leo Messi, Ronaldinho, and Roberto Carlos in the hepatitis elimination program. And we had several events in which we were addressing the public saying, you know what, hepatitis is a treatable disease. Now we have the treatment and we need to do the screening in order to treat the people. Also, we had a TV advertising by Leo Messi and a campaign, a global campaign saying, stop the wait. So instead of having patients in the queue for very long times because they don't have access to medicine, can we accelerate having those people to treatment? Then we have done local TV advertisements. Sorry, the video will not work here, but this was addressing the public on TV in the peak times, saying that, okay, treating hepatitis will improve the efficiency of the workforce of Egypt, people who are suffering from the disease, and families who are suffering from the burden of the disease will be in a much better situation, and hepatitis will be treated. That has brought us to the collaboration between the medical community and the health insurance, national health insurance programs, in addition to utilizing the mobile clinics and building all the data information, the data management system, which was built by the Ministry of Health, of course. And as FARCO, we also have our mobile clinics helping in the decentralized screening at the beginning in the different squares of Egypt. This is one of our trucks, if you could see, and the queues of people in the squares for rapid testing. And those who were positive, then they were forwarded to the treatment centers by the Ministry of Health. We also had those mobile clinics going to the large population manufacturing facilities of different companies, gas whales, large-scale manufacturers who have high population of workers and so on. For example, here you see Roberto Carlos, the football player, inside the convoy, inside the truck, and sharing with people the good moment in which the patient sees that she is negative, for example. And this is bringing as well the people to sensing that everyone is with them against hepatitis C. So looking at affordability side, as I mentioned, it's multiple dimensions. One of them is when we develop the drugs, we work on making the medicine active pharmaceutical ingredient affordable, and the manufacturing side to be according to GMP and then WHO pre-qualified. The diagnostics, as I mentioned, the economies of scale allow for cost controls. The donors, we looked at different donors. The biggest donor, of course, was the Egyptian Ministry of Health, the Egyptian government, which sponsored the program, as well as the national fund initiated by the president, Tahya Masr. The other donors from the region, Arab donors who donated, for example, for the treatment of 100,000 patients and so on. We, as FARCO, we were giving two different bodies large numbers at cost to allow for accessibility and affordability. Also, Bait al-Zakah, which is the religious part that takes the zakah from people, allocated good part to the treatment as well of the patients. We also developed a local manufacturing facility for the active pharmaceutical ingredient in order to be able to supply large quantities. As Dr. Qureshi was talking about the supply, part of it is making the material available, but the other part, which is very important, is synchronizing between the forecasted number of screened people, how many positive patients will come out of them, and the demand required, and accordingly the manufacturers to be able to manufacture ahead of time, 3 to 6 months ahead of time, the supply required. That allows for smooth streaming of the supply. One of the challenges you will see that when you start to see that the country is treated from hepatitis, the majority of people are treated from hepatitis, you might be left with stocks that are not utilized. But this is part of the cost. I mean, at the end of the day, this cost could be allocated to other countries in which they still have, which what Egypt did. The costs were and the products were allocated to other sister and neighbor countries that are were in need for hepatitis C treatment. But we made sure that the supply of the medicine does not get interrupted. And our capacity now is able to cater to several countries at the same time, provided that we have pre-agreed demand plans. At the end of the day, our purpose is to have both rich and poor people are on the promise of leaving no one behind for the elimination of hepatitis. From a discovery point of view, we after already the success with hepatitis C, we were able to have a handheld screening device that could help in diagnosing in early screening of individuals. It's a handheld device that could give positive indicator. Then those people who with positive indicator can go for rapid testing and PCR to have a confirmatory test. We tried to allocate this for COVID-19 when at the COVID time. However, if a mass screening is required, this could be the first step in mass screening that could be followed by rapid testing and PCRs. How could we improve in accessibility? It's a very simple answer. Let's accelerate working on it and acting on it instead of we keep speaking about it. This is why we call everyone that we can work together. And I thank everyone here for being available, and together we can make a better tomorrow for hepatitis elimination and obviously for all humankind. Thank you for giving me the time, and I hope I was able to stick to the time allocated. Thank you.
Yes, thank you so much, Dr. Fahmy, for the very interesting talk and for the creative approaches that you just presented. Finally, we will go back to Dr. John to learn more about the UN Group of Friends to Eliminate Hepatitis before handling the question and answer session. Back to you, Dr. John.
Thank you very much, Nadine. If you could show my slides, I will give you all a quick overview of the development of the first United Nations Group of Friends to Eliminate Hepatitis. I greatly appreciate being part of this regional meeting today and seeing the diverse number of countries that are represented on this call, and hopefully getting a clear message that advances can be made in hepatitis elimination in their areas. If you just could go to a slideshow. Thank you so much. Next slide, please. That's my disclosures. Next slide. I became about 2 years ago, actually about this month, 2 years ago, became aware of UN Groups of Friends, which is a way that member states of the United Nations come together on issues of common concern. And they're called a group of friends because they want to keep them informal, avoiding treaties and agreements that take years to develop across countries. And so we saw a value of having one to eliminate hepatitis. To accomplish these objectives, to promote health diplomacy of the type you've been hearing a bit about today from colleagues such as Amir from FARCO and the work of country of Egypt with other countries, serve as a forum to exchange lessons learned and to bring other partners to the table, both private and large nonprofits, to build capacity for hepatitis elimination. Next slide. We had our first kickoff event in September of 2022 during the United Nations General Assembly, when about 17 member states came together and said, yes, we want to form the first UN Group of Friends to eliminate hepatitis. The gentleman on the far right is the CEO of FARCO that the Amir just mentioned, Dr. Shireen Helmi. Next slide. And at that time, those were the countries that had joined the UN Group of Friends. And the ambassador to the United Nations for Egypt stepped forward and said, I will lead the UN Group of Friends to eliminate hepatitis. Next slide, please. At that point, we announced a partnership between Egypt and Ghana, whereby Egypt was providing HCV medications to Ghana to help start their first national hepatitis C elimination program. an example of the health diplomacy that we seek to promote through the group of friends. Next slide. The permanent mission, the ambassador of Egypt to the United Nations sent out a call for all member states to join, and we had a webinar to kick this off in early 2023. Next slide. And this was the letter that was sent to all missions at the UN. Next slide. Our job as the Coalition for Global Hepatitis Elimination is to serve as the secretariat, help convene the meetings, and disseminate communications, and continue to join with Egypt and others to promote participation in the group of friends. Next slide. And then we announced that with Dr. Khalid Ghaffar, who is the Minister of Health to Egypt, to put this in the scientific literature to document the launch of this group of friends. Next slide. We had our second meeting in September of 2023, whereby we seized on the focus on universal health coverage at the United Nations with a high-level resolution going through for adoption. And the group of friends had a role in assuring that hepatitis elimination was mentioned in that high-level resolution, an example of the impact a global group of friends can have. Next slide. Now, fortunately, the group of friends has grown to 41 countries, with the countries of Chile and Portugal joining Egypt in what we call the leadership circle for the group of friends. It's been commented by the WHO office at the United Nations, which helps to coordinate this group of friends, that this is one of the fastest growing group of friends that they have experience with over the last number of years. So that's good news to hear. Next slide. And this was the example of the viral hepatitis statement as part of the high-level resolution on universal health coverage. Next slide. I don't know if these will... we have several videos to give you an example of the types of statements at the group of friends. Excuse me.
We can share them, Doctor, if you don't mind. We can share them
Yes.
with the when we disseminate the link to the Zoom to the participants.
Sounds perfect. Next slide, please.
Thank you.
And these are examples of international organizations participating. Next slide. Again, international organizations making comments such as Gavi about their new support for hepatitis B birth dose vaccination in eligible countries. Next slide. This is sparking other collaborations with a group of friends. This is just an example of the country of Moldova visiting the task force, expressing their interest in doing more for hepatitis elimination. Next slide. Next slide. This is an example of a meeting we had with the Ministry of Health and the government of Egypt, actually, in Cairo last June of 23, bringing together ministries of health from a variety of African countries. Next slide. And other activities that are coming from the UN group of friends with examples shown here. Next slide. We look to, this is just an event we had at the U.S. Capitol, where the ambassador, the missions of Egypt and Portugal, which were in the leadership circle, attended this event to just an example of growing international collaborations that are made possible by the group of friends. Next slide. We also look forward this year to have technical briefings to increase awareness of the health threats of hepatitis and the benefits of hepatitis elimination. And we're in discussions to do this at the UN as well as in Washington, D.C. Next slide. Third annual meeting will be the 23rd of September during the UN General Assembly. I encourage all of you on this call to step forward and work with us at jward at taskforce.org and to see how your country can become associated with the UN group of friends and come and have a representative come to this meeting during the UN General Assembly. We greatly look forward to working with all of you in that regard. Next slide. And I think that's it. We have a video that you can watch on our on the slide set that you'll be receiving. All of this information is also available on our website at globalhep.org. And I look forward to working with all of you to eliminate hepatitis in your countries. Thank you.
Thank you so much, Dr. John. That was quite useful and interesting. Thank you. We have 2 minutes for the question and answer. So we picked only 2 questions that are somehow similar for Egypt and for Pakistan. We have 2 different questions that tackled whether the hepatitis C elimination or the screening packages or the campaigns include the migrant population or the refugees in both Egypt and Pakistan. Can we briefly have an answer from each of Dr. Muhammad and Dr. Huma about the inclusion of the refugees or the migrant populations? Thank you.
So if I jump in first, so I'll just let you know that we have got 2 phases of our plan. So in the first phase of the plan, it's not there. But in the second phase of the plan, when we are also taking in the children who are less than 12 years of age, in that plan, we are including the migrants and the refugees. Thank you.
Thank you, Dr. Huma. Is Dr. Muhammad with us? Dr. Muhammad is no longer. Yes.
I think I can take this
yes,
question.
Please.
Yes,
yes, please,
actually,
Doctor.
Sure. During the screening program and the 100 million health project, 100 million صحة, all population, adults in Egypt, and regardless of nationality, were screened. We don't have this part that says those are refugees and those are Egyptians. We are all living in Egypt. We get the same prioritization. Now, after the hepatitis elimination program reached the golden tier and concluded, the refugees are flooding in a stage in the last 12 months to 18 months again. And this is what the government is nationally addressing now and trying to, like, having numbers and structured numbers for those refugees. And then they will be, I am sure they will be incorporated into a national, I cannot speak for that one on behalf of the government, but I'm sure as was done in the first stage, most probably it will be done again with the refugees when the data is available for them or immigrants.
Thank you so much, Dr. Amr, for answering this question. Unfortunately, we cannot take further questions for the sake of time. We have reached the end of the webinar, and we hope that we were able to raise awareness about the significant burden of viral hepatitis B and C in the Eastern Mediterranean region. As we learned that elimination is crucial and it can be achieved, Egypt set the good example of a success story in which a multi-sectoral and long-term commitment and joint efforts were deployed. In the region, we need country-specific and regional efforts for enhancing domestic resources, implementing and scaling up prevention, testing, and treatment. And we hope that we were able to provide an insightful perspective by sharing the lessons learned and the best practices within the Eastern Mediterranean region. We would like to thank once again our panelists and the attendees for joining us today. And thank you so much and good evening, everyone. Thank you.
Thank you so much. Thank you.
Thank you.
Thank you very much. Good to see all of you here.
Bye.
Bye.